In this video, we're going to talk about the electrolyte potassium. So potassium comes in a normal range of approximately 3.5 to 5.0 milliequivalents per liter. So hyperkalemia would be a state that is higher than 5, and hypokalemia would be a state that is lower than 3.5. Potassium is a very prominent electrolyte in the body, and it maintains our fluid and electrolyte balance. You guys probably remember kind of one of the first things we learned in biology is about the sodium-potassium pump and how 3 sodium are pumped out of the cell, 2 potassium are pumped into the cell, and because of this, it should make sense to you that intracellular potassium is very, very high compared to extracellular potassium. That is to say, there's more potassium inside the cell at baseline than there is extracellularly. And we'll talk more about why this is important. So first, let's talk about states of high potassium or hyperkalemia. Some of the primary causes include intracellular release. And I've highlighted 2 specifically here, TLS, which is tumor lysis syndrome, and rhabdomyolysis. So why can these cause high levels of potassium? Because remember what we just said, that potassium inside the cell is much greater than potassium outside of the cell. So if we have large amounts of potassium inside of the cell and small amounts outside of the cell, what's going to happen if we have tumor lysis syndrome or rhabdomyolysis, which is essentially cellular damage that causes the cells to lyse or break? Well, what happens is that potassium is going to leak from inside of the cell to outside of the cell. Because the cell membrane is destroyed, potassium leaks out into the extracellular space. This can be measured in our serum labs as a hyperkalemic state. Tumor lysis syndrome and rhabdomyolysis, I think, are the 2 most common ways that they will test you on at this level. But another way this can occur is due to errors in drawing of the blood, or lab technique, essentially, in that the red blood cells can actually lyse during this process, which can cause the serum labs to measure a falsely elevated high level of potassium, or something we call pseudo-hyperkalemia. And so I'll highlight that right here. Pseudo-hyperkalemia, or falsely elevated potassium levels, can also be due to lab error that causes the same process, which is lysis of the red blood cells. Another way that hyperkalemia can occur is due to various medications, such as ACE inhibitors, ARBs, or potassium-sparing diuretics. We'll dive much more into the mechanism behind why those cause hyperkalemia in the pharmacology section. However, it's important to know that a potassium-sparing diuretic should make sense, right? If you give too much of something that spares potassium, that can cause a hyperkalemic state. But with ACE inhibitors and ARBs, the main mechanism by which they work, ultimately through blocking part of the RAS system, is that they decrease aldosterone secretion. And we know that aldosterone is very important in the reabsorption of sodium at the expense of secreting more potassium. And so a very simple overview is that aldosterone works to bring back sodium into the body. And through mechanisms that are discussed more in the nephron transporter series and pharmacology section, it will secrete potassium. And so if we give these medications that essentially decrease the amount of aldosterone that we're secreting, we are essentially blocking this process, and thus we'll get the opposite effect. Instead of secreting and excreting more potassium, we would retain more potassium, and thus we can have a hyperkalemic state. And finally, decreased excretion or even increased intake can obviously cause us to have a higher level of the potassium, the electrolyte, if we're not expelling it from the body at the appropriate rate. Next, let's move on to some secondary causes of hyperkalemia, and that includes decreased insulin and beta blockers. I'm lumping these 2 together because the mechanism by which they cause this high potassium state is essentially the same. And the reason is that the insulin molecule and beta agonists both serve a role in stimulating the sodium-potassium pump that we've talked about previously. So both of these act to positively stimulate the sodium-potassium ATPase. What's that going to cause? It's going to cause more sodium to leave the cell and more potassium to go into the cell. So in this scenario, we're saying that decreased levels of insulin and beta blockers, which do the opposite of beta agonists, are going to have the opposite effect. They are going to slow down the sodium-potassium ATPase. And what's that going to do? Well, if you have low levels of insulin and beta blockers, you're going to actually inhibit this channel and slow it down. So then think about what happens. We're going to have less potassium pumped into the cell, less sodium pumped out of the cell. And what's that going to do to the overall potassium levels? It's going to cause more potassium to be outside of the cell because this transporter is working slower if we give them these medications. And thus this can cause a hyperkalemic state. A very similar cause is digoxin toxicity, which can also cause a very similar presentation because it has a similar mechanism in that it causes inhibition of the sodium-potassium ATPase. Again, same thing here. This is going to cause a buildup of potassium outside of the cell. And finally, we have the state of acidosis. So it's really important to understand the physiology here. If you understand the physiology of why this occurs, then you can apply it to many different types of questions that they could ask you. So in acidosis, we have a really high level of hydrogen protons extracellularly or outside of the cell, which I've highlighted here with a big H outside of the cell and a small h inside of the cell. What happens then is that this high level of acidosis can actually inhibit a transporter on cells called a sodium proton antiporter, which typically acts to bring sodium inside of the cell and send protons outside of the cell. If we have inhibition of this transporter, it is going to decrease our sodium gradient that we typically have. And if we decrease our sodium gradient, that can then inhibit the sodium-potassium pump. And now we get the same presentation that we just talked about with some of these medications, in that if you inhibit the sodium-potassium pump, which typically puts potassium inside of the cell, well, now you've blocked that reaction from happening. That's going to cause a buildup of potassium outside of the cell, causing levels of high potassium. So we walk through this process again. High levels of hydrogen protons outside the cell, or an acidotic state, can then lead to inhibition of the sodium hydrogen antiporter. This throws off the sodium gradient so that we then have inhibition of the sodium potassium ATPase transporter. And again, if we block this, we block the ability of potassium to get pumped into the cell, and we can have a high level of potassium extracellularly or outside of the cell. Next, let's talk about some common presentations, and these include things such as cardiac abnormalities, arrhythmias, and weakness as well. Remember that potassium plays a vital role in fluid and electrolyte balance, as well as cellular membrane resting potential. Remember that our resting membrane potential is typically at a negative value, and when these cells are excited, the potassium will essentially rush through it, creating more of a positive membrane potential, which is essentially what allows our cells to fire, right? Our neurons and stuff to secrete that signal. It's really based on our sodium and our potassium changes within the cell. So this should make sense then that anytime you have a derangement or an alteration in the potassium levels, such as too high potassium or too low potassium, this can alter cellular membrane stabilization and ultimately cause some problematic things such as these arrhythmias or cardiac problems. And these can be very serious because they can ultimately lead to ventricular fibrillation, which can be a life-threatening thing for a patient. Weakness is a little bit more of a non-specific finding, but note that it can be associated with both high levels of potassium and low levels of potassium. For patients who have a presentation that's consistent with hyperkalemia, it's really, really important that you get an ECG. And the reason is that an ECG finding of peak T waves or a widened QRS complex is very important to know, because patients with changes in their ECG are at a much higher risk of then developing arrhythmias. So you're really not expected to know a ton in terms of reading ECGs or EKGs at this level, but it's important to know some of the basic findings and the really important stuff to know, and one of them is the peak T waves. So just as a quick review, a typical EKG might look something like this, where you have your P wave, your QRS complex, and a T wave. But in a patient with hyperkalemia, notice that the P wave and QRS are relatively the same, but the T wave is peaked. It has this very prominent peaked appearance, and that is indicative of a high potassium state in the patient. And finally, for the management of these patients, the first thing you want to do is always to look for what's the underlying cause and try to treat that if you can. But if patients have severe hyperkalemia and they're starting to develop EKG changes, you need to address those things a little more promptly. And one of the first things you want to do is administer IV calcium gluconate. This is a medication that stabilizes the myocardium in the heart. And we talked about the importance of trying to avoid arrhythmias because they can ultimately lead to very serious life-threatening complications. And so one of the first things, if not the first thing you do, is to give this calcium gluconate to help decrease the risk or prevent these further complications from occurring. Another option is to give patients insulin and glucose. We talked about how insulin stimulates the sodium potassium ATPase, and thus if you give them insulin, you can stimulate that pump, which will put more potassium inside of the cell. We note that we're giving some glucose as well because insulin is also playing an important role in absorption of glucose in the body. And so if you just gave them insulin in isolation, yes, you'd be improving their potassium state, but you might be causing them to have a hypoglycemic state. So you give them together in order to keep a balance. Beta agonists can also be used. We talked about that mechanism, how it stimulates the sodium potassium ATPase as well. And additionally, you can give them something called a cation exchange resin. And these are medications that will release sodium and calcium ions, which are then exchanged for potassium in the gut, ultimately leading us to allow our body to excrete more of that potassium because we have too much of it to begin with. And finally, you can use dialysis for any severe derangement in the electrolytes in the body. Next, let's move on to hypokalemia, or low levels of potassium. So primary causes include GI loss, such as vomiting or diarrhea. This should make sense, right? If we're continuously excreting fluids, and we say a lot of our fluid component is potassium, well, that's going to cause us to excrete lots of potassium. There can also be renal loss, such as RTAs type 1 and type 2. This pathophysiology is discussed a lot more in our RTA videos, so feel free to check those out if you are unfamiliar with this process. But we can also get it from medications. So these include things like loop diuretics and thiazide diuretics. Again, anytime we have a medication that causes us to excrete a lot of fluid, this is likely going to cause us to excrete a lot of our potassium because so much of our fluid contains our potassium. A secondary cause of low levels of potassium includes low levels of magnesium. Why does this occur? Well, it's because magnesium inhibits the ROM-K channels, and thus it increases urinary potassium loss. So what do I mean by that? Is that at baseline, magnesium inhibits this channel right here, this ROM-K channel, which typically allows potassium to flow out. So if we have an appropriate amount of magnesium, we can have this channel inhibited. However, if we lower our magnesium levels so much that we wipe out some of this process, we're going to lose this inhibition right here, which means this channel will not be inhibited by magnesium at all. This is going to cause a greater release of potassium through it. This is going into the lumen and the nephron, and if we have more release through the ROM-K channels, more of it will then be excreted from the body. So this is the physiology of how low levels of magnesium can cause low levels of potassium, and it should make sense to you then that you cannot correct low levels of potassium if the patient continues to have low levels of magnesium. You must treat both of them together. Another secondary cause is alkalosis, and this is pretty much the opposite mechanism of what we talked about for acidosis, causing high potassium levels. And so we won't go through it again, but an alkalotic state means there's low protons outside the cell. This is going to then stimulate the sodium proton antiporter, which will then stimulate the sodium potassium ATPase. And if we stimulate the sodium potassium ATPase, what's going to happen? Well, if we stimulate this, then more potassium is going to go inside of the cell, which can cause a decrease in potassium outside of the cell, and thus a hypokalemic state. There are some key similarities here in terms of the presentation for low potassium levels, such as cardiac abnormalities, arrhythmias, and weakness again. So you're probably asking yourself, well, how would I tell the difference in a question stem? If they give me a patient, how do I know if it's high or low potassium? And the key here is, one, they can make it very simple and give you the labs, unlikely, but more likely is they're going to give you the ECG and expect you to interpret it correctly. So we talked about the key findings on hyperkalemia, but on hypokalemia, we're looking at a couple different things, such as U waves and a flattened T wave. A flattened T wave should make sense to you thinking about the last diagrams we looked at, but the U wave is essentially just a little change on the ECG that occurs after the T wave. So I've highlighted it here in pink. I would also encourage you to maybe Google some images and kind of get familiar with what these look like on an actual ECG findings versus my non-specific drawings. And finally, the last thing we're going to talk about for potassium is management. So potassium supplementation and or magnesium supplementation if necessary. We talked about why correcting magnesium is important to ultimately correct the potassium level. And also you can use potassium sparing diuretics. This should make sense, right? If we're giving a potassium sparing diuretics because they have low potassium levels, that should help elevate their potassium levels.